Okay, just for a little introduction, Carlota.
Okay, yes,
On behalf of
thank you very much.
H.Hemo, I would like to thank you for your time and to being here with us today. We are very grateful for you and also for Therakos to make it happen. So maybe you can have your talk, your lecture, and after that we can have a little question and answer sessions. And I think we'll have a lot of improvement in our knowledge about ECP. And so you can start. The stage is yours, please.
Thank you. Thank you very much again for the invitation. For us, it's a pleasure to be here with you. Yeah, and I would like to thank for extending the invitation to all the members of Grupo H.Hemo. And well, as mentioned, I will focus on GVHD, which is maybe the indication you are more interested, but I will also explain some aspects about the other indication. And as mentioned, for any question, you interrupt me during the session or if you want to wait at the end. So I'm going to start presenting about ECP. What is, I would like to introduce a little bit about Therakos ECP immunomodulation. What is ECP? Because maybe some of you know this medical procedure, some of you may not know it still. So ECP is a immunomodulatory therapy that has demonstrated its efficacy in different T-cell and immunomediated disease. And one maybe of the main difference of ECP as immunomodulation with other immunosuppressive therapies is that it has not been associated with an increased incidence of infections and neither with an increased risk of secondary malignancies, which is the case with immunosuppressants that are used for the same indications. And I think that this is an important aspect. Then, what is Therakos ECP? Therakos ECP is a therapy that is considered as well established for especially advanced stages, as we have mentioned in the introduction, of refractory cutaneous T-cell lymphoma, but it has also demonstrated its activity in other indications. We have mentioned graft-versus-host disease, both acute and chronic, solid organ transplant rejection. Here we are especially referring to lung transplantation, heart transplantation, and kidney transplantation. In this setting, it has been used because we won't comment more in this presentation. I have not prepared anything special about solid organ, but I would like to mention that ECP has been used both when the rejection is established and also to prevent rejection. For instance, to prevent rejection, there are studies that are from 1998. There is one study in the New England where ECP has demonstrated its efficacy to prevent heart rejection. So there are also guidelines that include ECP in the management of the solid organ transplantation rejection and for the prevention of this rejection. And we also have some other disease like autoimmune disease, as is the case of systemic sclerosis. ECP has also been used. These are maybe the main ones, but if we look at some literature, we have also other indications, especially maybe dermatologic ones. For instance, we have lichen planus that has also been treated with ECP, atopic dermatitis. Maybe these are not so frequent ones. We don't have so many patients, but it's important that because at the end, ECP is a treatment that provides immunomodulation. It has been used in different diseases where this immunomodulation can have a positive impact. I would also like to mention that ECP has been used since 1987 when it has been first used in a clinical study. It has been used in more, we have done more than 1 million treatments with this technology. I would like to mention also the history of Soralen, because When you use ECP with Therakos technology, you are using a photoactive substance, which is the drug called 8-methoxysoralen, which is also referred as methoxsalen. And these soralens have been known since the ancient Egyptians because they have shown medicinal properties when they were activated by sunlight. So ECP has been used since 1987, but soralens have an old history in the medical field. I would like also to provide, regarding Therakos ECP, we mentioned that since 1987, it has been started to be used, but I would like to provide some historical data. Because it has been first introduced as a treatment for cutaneous T-cell lymphoma. This is the clinical development of Therakos ECP in CTCL. The first data come from 1974, when some patients with Sézary syndrome were treated with leukapheresis. You know that leukapheresis is the first phase of ECP, of extracorporeal photopheresis. After, in 1979, they have shown that CTCL could be treated in a palliative manner with PUVA therapy. At the end, they have, in 1982, they have reached the idea that maybe combining the leukapheresis with the irradiation in the presence of a photoactive substance, this can help in the management of this patient. And this had led finally in 1987 to the publication of the first prospective international multicenter trial that has been published by Edelson and collaborators that has shown that ECP may reduce the symptoms of patients with cutaneous T-cell lymphoma. This has led to the FDA approval of Therakos ECP technology in 1988. After this approval by the FDA in 1992, in these patients that have improved, especially the symptoms have improved, it has been demonstrated that ECP, apart from improving and having a clinical response regarding symptoms, it has also provided an improved survival in this patient. So not only a clinical response, but also a survival advantage. But apart from CTCL, since 1989, we have other publication and evidence that links ECP with other indications. For instance, we have mentioned before systemic sclerosis as an autoimmune disease. In 1989, we have the first report, the first case report, that ECP may improve skin thickening, the skin involvement in a patient with systemic sclerosis. In 1994, we have the first successful treatment of chronic GVHD that has been done with extracorporeal photopheresis. In 1 year
Foi feita
after,
falando a respeito de Madre Teodora.
In 1995, we have after the first report of use of ECP for treatment of acute lung rejection after lung transplantation. As mentioned before, in 1998, we have a study published in the New England of the use of ECP to prevent rejection in heart transplanted patients. In 2006, we have a randomized study of use of ECP in systemic sclerosis, and also we have additional evidence on the use of ECP in acute and chronic GVHD. In 2007, we have maybe one interesting study because it has evaluated the effect at mechanistic level of ECP in patients with lung transplant rejection, and it has shown one of the main mechanisms of action of ECP, which is the modulation of the lymphocytes Tregs, which are evolved in the immune tolerance in our immunological system. In 2008, maybe most of you may know the study by Flowers and collaborators, by Betty Flowers. The study, this is the first prospective, randomized prospective study, a phase 2 trial of ECP for chronic GVHD treatment. We can say that this is the only maybe randomized prospective treatment we have currently. And from 2009 until now, we have other publications regarding use of ECP in different immune diseases. Which is the mechanism of action of ECP? This is another question that has been assessed. Initially, because ECP has been used first in cutaneous T-cell lymphoma, which is a neoplastic disease and a clonal disease, especially it's based on a clonal expansion. It was thought that ECP mechanism of action was related to the depletion of malignant T cells. But they have postulated that when you do an ECP procedure, you don't treat 100% of the cells from peripheral blood, you only treat a small proportion. So it has been said and hypothesized that there are other effects. So you have a direct effect when doing an ECP procedure, but after you have other effects that may be originated when you perform an ECP treatment. But here you have one of the main mechanisms of ECP action, according to what is evidence until now. We have ECP may modulate dendritic cells. It can alter the cytokine profile. Normally, ECP changes the profile from a pro-inflammatory state to an anti-inflammatory state. And also the induction of some T cells of population I have mentioned before, Tregs, and it has been shown in different publications that ECP has an impact in Tregs in the different disease stages, and we're going to see it after also. This is an ECP procedure. Maybe some of you know what's happening when you are doing an ECP procedure to one patient, but I would like to explain briefly the different phases, the different processes that take place, both at molecular and cellular levels. I will also like to mention that here we speak about the different actions that take place, but Therakos ECP technology provides all steps, all actions in a single device. You don't need to disconnect the patient. It takes more or less, according to data published, more or less 90 minutes, between 90 and 100 minutes to do a procedure. And the patient is always connected to the device. There is no disconnection, and everything is integrated in one technology. The first action that takes place is that a small proportion of the patient peripheral blood is separated and collected in the integrated Therakos system after methoxsalen is added to this to the bag, and it's exposed to UV light in order to activate methoxsalen. This UV activation causes an apoptosis of some of the cells in the buffy coat that has been collected. And after the treated cells, once these cells have been treated, they are reinfused in the patient bloodstream. And after this reinfusion of these apoptotic cells, there is a cascade of immunologic effects. Some of these immunologic effects, as mentioned, have been an increase in anti-inflammatory cytokines, a downregulation of pro-inflammatory ones, and an induction of Tregs. It's very important, apoptosis. We mentioned that some of the cells go into apoptosis, and this will be the direct effect of ECP, because during the procedure, once the cells are treated, they enter into apoptosis. And this phenomenon of apoptosis has been demonstrated after ECP treatment in patients with CTCL and GVHD. And after this apoptosis, once the cells are reinfused into the patient bloodstream, there is a phagocytosis by immature dendritic cells. And after this phagocytosis, these cells acquire an immunotolerant phenotype, and there is also an induction in Tregs. I don't want maybe into details in this, but I would like to mention what has been proved according to the preclinical and clinical evidence of the mechanism of action of ECP. For instance, we have demonstrated that there is an eradication of clonal T cell populations in patients with CTCL. We also have references that ECP produce a shift in the antigen-presenting cell population in the different disease states. There is a shift in the cytokine secretion, as mentioned, from a pro-inflammatory or T1 helper phenotype to a T2 helper phenotype, which is more anti-inflammatory. And this has been shown in GVHD and solid organ transplantation. An induction of Tregs, as a reminder, Tregs are help to have an immune tolerant state in the organism, which is very important for GVHD, for CTCL, and for solid organ transplantation. And this has been shown in all the disease. And also there is, apart from having an impact in T cells, ECP has also shown an impact in B cell signaling, and also an increase in myelo-derived suppressor cells. This is what is known until now, but of course there are different ongoing investigations in order to demonstrate, to have more evidence linked to the mechanism of action, and also the correlation between the mechanism of action and the clinical response and the clinical outcomes. Another important aspect, especially in GVHD, but also in other disease states, is that ECP has shown that it doesn't suppress the immunity against new or recalled challenges. This means that after allogenic transplantation, ECP maintains an intact graft versus tumor effect, graft versus leukemia effect, and it does not increase the risk of relapse or the typical effects that conventional immunosuppressants have. It's also important that, especially studies with CTCL or systemic sclerosis, we have patients that have been followed up for many years, and it has been in these studies with long-term follow-up, there have been no evidence of increased infections or secondary malignancies. Now I would like to go directly into GVHD and the different studies guidelines that we have for ECP. Well, you probably know, so maybe we'll go faster on this regard. What is GVHD? You know that it's still one of the most serious and common complications of hematopoietic cell transplantation. And we have normally acute and chronic, but we have also some overlap. We have overlap syndrome with features of both acute and chronic, and is the leading cause of mortality after allogenic stem cell transplantation. As mentioned, these are the categories of GVHD, acute and chronic, normally depending on when the symptoms start after hematopoietic stem cell transplantation or donor lymphocyte infusions. And as mentioned, there is an overlap syndrome that has a mixture between acute GVHD and chronic GVHD features. Which are the treatment options of GVHD? This is a summary. It's not only about acute and chronic, it's in general, overall, the different treatments, more or less a summary. Of course, there are new agents that need to be added because this is a field, GVHD, you know that there are many trials ongoing. You always have every year new agents coming. Also, some of them have been approved by authorities. We have, for instance, ibrutinib has been already approved for chronic GVHD recently by FDA. We also have ruxolitinib has already been approved for acute. So every year we have new agents, and also we have different ongoing trials. But in general, we still can say that first line is still systemic steroids. I mean, steroids are still the first line treatment of GVHD, both acute and chronic. And after steroids in first line, some immunosuppressive therapies may be added, which are the second or third line options in GVHD. It depends on various factors. It depends on the type of GVHD, on the organs which are affected, on the severity of the disease. This may also condition the treatment that we are going to choose, concomitant diseases that one patient may have, and also the access to a therapy. Of course, this is something also to consider. Here is a summary of the second line options. These are the guidelines from the British Society of Hematology. They are one of the guidelines. And of course, these publication, maybe it's somewhat old because we don't have the new agents, but here you have some of the options for acute and some of the options for chronic. And you can see that ECP is mentioned both in acute and chronic. Now we are going to enter more in detail into acute and what we have about ECP in acute GVHD. As mentioned, for GVHD in general, acute GVHD is the major cause of morbidity and mortality in the hematopoietic stem cell transplantation setting, and is the main risk factor for the development of chronic GVHD after. And maybe we have improved the prophylaxis in order to avoid acute GVHD in the last years, but we still see development of acute GVHD and chronic GVHD. These are the main organs affected by acute: skin, gastrointestinal tract, liver, and in some, maybe in less occasions, eye and oral mucosa. And the skin is the organ most affected. And here are the main symptoms and signs of acute GVHD cutaneous involvement. Which is the treatment of acute GVHD? The exact incidence is very variable. If you look at the publication and the literature, you have estimated incidence range that vary quite in a wide range. As mentioned before, for GVHD in general, steroids are still first-line therapy. They have demonstrated their effectiveness. The problem of steroids is that there is a low rate of durable complete responses with steroids. This is more or less the percentage. And the problem is that when a patient develops a steroid refractory disease, because it's difficult to manage, this steroid refractory disease is associated with high morbidity and mortality. And normally these refractory patients respond poorly to other therapies. It's also important to mention that currently nowadays there is no standard treatment for steroid refractory disease. We have different agents available. Guidelines speak about different agents, but there is no standard treatment. Depending on the patient, as mentioned before, depending on the comorbidities, depending on the organ affected, maybe we can choose one or a combination of therapies, or start with one therapy and move to another one if the patient is not responding. Here we have the definitions, because when we speak about, we have spoken about steroid refractory, but we also have steroid dependency. And here are the definition of mainly the main. We also have steroid intolerance and the main definitions. What do we have about ECP in acute? These are the treatment recommendation. I would like to mention one publication from the American Society for Blood and Marrow Transplantation. This is from 2011. I would like to mention regarding ECP, what has been mentioned in these recommendations published by Martin and collaborators. I would like to especially point out, because we mentioned that second line, we don't have a standard treatment, we have different options, but regarding ECP, this group made an assessment of the different characteristics of the different second line treatment. And if we look at ECP, if you look at toxicity concerns, they are limited. And ECP has no significant interactions, and there is no increased risk of viral reactivation. Here you can see from this Martin publication, because of course it's 2012 published, you have the different agents that at this time were used in the second line setting of acute GVHD, and the main aspects of toxicity, interactions, and viral reactivations concerns. You can see that maybe ECP regarding these aspects has a positive aspect of, and especially that has been used since 1987, and we have maybe data on the, especially on this, on the safety and on the lack of significant interactions. I would like also to mention the clinical practice guidelines for ECP in acute. We have different guidelines at international level, and also these guidelines, some of them are updated periodically. For instance, the American Society for Fotoaférese, the last guidelines from these institutions are from 2019. But if we look at the recommendation on ECP use for acute, it's more or less the same. They have not changed in the last years. So ECP, according to these guidelines, are accepted as second-line option for acute GVHD with both cutaneous manifestation and non-cutaneous involvement. We also have the British Society's guidelines that also suggest ECP in second line. We have the Canadian ones also mentioning ECP in both adult and pediatric patients. We have Italian guidelines, the societies, the hemapheresis and bone marrow transplantation societies. These guidelines are from 2013, and also they mention ECP as an option for acute GVHD, which is refractory to steroids. And they also mention that ECP can be used in patients with acute GVHD that are refractory also to calcineurin inhibitors. And something important is that in these guidelines, they mention that early start of ECP. So once acute GVHD that is refractory to steroids is diagnosed, start as soon as possible the treatment with ECP. There is always, in the UK, we have the Fotoaférese Society, and they always have provided a consensus statement, also recommending ECP in acute. And in these guidelines, in the UK guidelines, they also recommend, mention that ECP has an excellent safety profile, and there are no reports of increased infection or disease relapse. And finally, we have the European Dermatology Forum guidelines. These are guidelines published in Europe, but they have a impact. I mean, they are known also worldwide. They are published by Nobler. They have been published initially in 2014, and they have been updated at the end of 2020. This guideline, I would like to mention if someone is interested, because the other guidelines are mainly about GVHD. But EDF guidelines, apart from GVHD, they do a review of all ECP indications. So if someone is interested in look at which is the evidence that we have according to use of ECP and the different indications, we can look at these guidelines and you have a review of all the evidence. Regarding acute GVHD, these guidelines mention that ECP can be used in patients that are refractory to first-line steroids. They also mention that ECP is well tolerated with an excellent safety profile in adults and children. And also they mention the early start of ECP. They also mention an intensified schedule. We have different studies. You know that the treatment schedule for GVHD, there are different, every publication maybe has a different treatment schedule. But they have shown that maybe for acute, starting early is something that has been shown an improved outcome, and also maybe an intensified schedule in some cases of acute GVHD. And also, it's also important a rapid tapering of corticoids, because this can impact also the patient survival in the long term. So these are the main guidelines. Of course, as mentioned, these guidelines, some of them periodically, they do an update. For instance, as mentioned, EDF, they have published recently. So it's something that is very dynamic, but I think that we have different guidelines at international level that suggest and accept ECP for, it's important we are mentioning steroid refractory acute GVHD. We don't have at the moment any guideline that's maybe describe or recommend the use of ECP in other lines that is not steroid refractory. Which are the clinical data we currently have on ECP in acute? These are all the publication, of course, because of the time, we don't have time to enter into detail of the publications. Maybe if you are interested, we can do it another session, but these are the main publications from 1998. We have the first by Greinix. Here you have the different study design. We have mainly retrospective, but we have some prospective data, as the one from Greinix in 2006. Here we have the complete response and the partial response. And maybe I would like to point out as the main studies, maybe because of the number of the patient, the design. We have, as mentioned, the study from Greinix, 2006, 59 patients with a complete response of 70 and a partial response of 10%. When we look at 70% of complete response, they have also done an assessment by organ. And I would like to mention that we have an 82% complete response in skin, 61% in liver, and a 61% in gut. So at the end, this is the medium one for all the organs, but we have also good values for the 3 organs. And it's also important that if they have looked at the probability of survival, and patients who have responded completely to ECP have had an increased probability of survival, 59% at 4 years, as compared to patients that have not responded in a complete way, in a complete manner. Maybe another study is the one from Madame Jagesia in 2013, retrospective one of 57 patients. In this case, it was a control study. There was a group treated with ECP and a group treated with anti-cytokine treatments. In this case, of course, it's retrospective. We have confounding factors, but they have found a complete response of 54% and a partial response of 12%. And another important aspect is that they have looked at survival. And ECP was an independent predictor of survival. So there was a significant difference in the survival in patients treated with ECP as compared to patients treated with anti-cytokine therapy. And maybe as the last study I would like to point out is the one from Dasgupta, Emma Dasgupta in 2014, retrospective, 128 patients. And I would like to mention this study because, you know, there is normally in acute, we look at response at 28 days or at 56 days. But in the last years, they have introduced maybe a new endpoint, which is a composite endpoint, which is a combination of response, lack of death, lack of disease progression, and lack of introduction of a new immunosuppressant. And this study from Dasgupta has introduced this composite endpoint in the assessment of ECP efficacy. And it has proved that ECP treatment at 6 months has this composite endpoint of 77.3% with a 2-year survival rate of 56%. These are maybe, of course, as mentioned, I cannot enter in detail, but if someone is interested in one of these studies, I can send to you the link. We have mentioned all these studies are in steroid refractory, and all the guidelines speak about ECP in steroid refractory. But I would like to mention one study that has been done in patients in first-line acute GVHD. This is a phase 2 randomized trial done by Alusi and published in Blood in 2015. Only to mention, in this case, this is a phase 2 randomized Bayesian design study. Patients with acute GVHD who received, as mentioned, this is first line. These patients have received less than 3 days of systemic steroids. ECP has been given together with steroids in an intensive manner in the first 50 days. And after, these treatments have been spaced, and the primary endpoint has been the treatment success at day 56. This is, as mentioned, a randomized study with a Bayesian design. And they have also assessed the impact of ECP in the T-cell subpopulations. These are the results. Because it's a Bayesian design, there has been a pre-established success rate, and they have shown that the probability, so the ECP plus steroids combination has a probability of success that was higher according to the predefined threshold as compared to steroids alone. I would like to mention that especially, so this is the total the treatment success at day 56. This is for the combination. This is for corticoids only, but especially the difference has been seen when there has been a skin involvement. So this is the difference, 72% for the combination, 57% in skin. In organ involvement, more or less, the efficacy is the same using ECP in combination or only steroids. They have also looked at the reduction of the dose of steroids, and they have seen, despite not being significant, that at day 28, there has been a reduction to less than 0.25 milligrams per kilo of steroids in 23% of the combination versus 10% in the group only treated with steroids. And at day 56, they have seen that 43 patients have less than 0.1 milligram per kilo versus 30% in the steroid group. And this is the values of non-relapse mortality, which are more or less the same. They have also assessed, as mentioned, the levels of T cells, and we can see that the combination of ECP plus steroids has a statistically significant impact in the level of T regulatory T cells that, as mentioned, help to have an immunotolerant state in the organism. So as a conclusion, of course, these are preliminary results, but these results suggest that ECP added to steroids in first line can provide a higher response rate and also facilitate the reduction of steroid dose in patients that have been diagnosed with acute GVHD. It's true that it's also, this impact is especially in patients that have cutaneous involvement, and also from a mechanistic point of view, they have shown that the impact is also on the level of T regulatory T cells, because they have seen a significant increase in the level of T cells, these T cells in patients treated with the combination. Apart from this study, in the this year, we have had a randomized trial published by Meta in the United States, which was a randomized trial also in first-line acute GVHD treated in combination of ECP with steroids. If someone wants to look, and I can also send to you the link. So there are, in the last year, maybe some publications stating that ECP can have a potential effect in the first-line setting in combination with steroids. What about chronic GVHD? This is more or less the introduction. Is also a common, chronic GVHD is a common late complication after stem cell transplantation. In this case, any organ can be involved, almost any organ can be involved. There are different grades, mild, moderate, or severe, according to the severity of the disease itself and the number of organs that are involved. The incidence rates are very, very wide. It's the same than acute. If we look at the numbers of epidemiologic data, there is a wide range of incidence. We have, the new prophylaxis regimens trying to prevent GVHD have had maybe an impact in preventing, especially maybe acute more than chronic, but we still see a high incidence of this disease that has also a high morbidity and mortality impact. Which is the treatment landscape? As it's the case in acute, the standard first-line treatment is corticoids. Normally, to these corticoid treatments, they add other immunosuppressive agents. The problem of chronic GVHD and the treatments that are used for chronic is that they cause delayed immune reconstitution, and this results in an increased risk of infections and other complications. And we need to know that also the drugs that are treated, they are also immunosuppressive, so they increase the risk of infection. And also infection is the most common cause of death in patients with chronic GVHD. And it's important, as mentioned, that normally chronic is a chronic disease. There is a need to look long-term treatment with immunosuppressive, and this long-term treatment is associated with morbidities and complications, especially reduced immune function and increased risk of infection. These are the main definitions. We have steroid refractory disease, steroid-dependent disease, and steroid intolerant disease. And what about, what do we have regarding ECP in chronic GVHD? As mentioned before, there have been in the past some reviews of the different options for second-line treatment in chronic GVHD. I would like to mention this one from Wolf, which is a European consensus document that has been done in 2011. Of course, 2011 we can consider maybe somewhat old, but I would like to mention that ECP was mentioned with C1 level of recommendation of grade of evidence 2. As the main limitation of ECP at this time, the fact that ECP, it requires a venous access, but as comment of maybe the potential differentiated aspect of ECP is that it's a steroid sparing agent, especially in chronic, and it has an excellent safety profile. So as mentioned, if we look at the level of recommendation, C1, which is the level that is provided for ECP, means that the use in second-line treatment of chronic is justified. And if we look at the evidence, the grade 2 of evidence means that there is more than well-designed clinical trial, and so that we have, we can say, a moderate level of evidence. And these, well, maybe I'm going to, yes, these are directly the clinical practice guidelines that mention ECP treatment in chronic. Most of them are the same ones that are for acute. So for instance, we have ASFA also that mention the use of ECP in chronic. It's also accepted as second-line option for chronic GVHD with both cutaneous and non-cutaneous. In this case, according to ASFA, the level of recommendation is slightly higher than in acute, because maybe we have more evidence than in acute. We also have the consensus document from Wolf and the consensus clinical practice document. In this case, it was only published for chronic. The use in second line of ECP is justified. It's also important that in patients that respond to ECP, this consensus document mentioned that there have been significant improvement in the survival rates and also improvement in quality of life. We also have the British guidelines that also mention ECP as a second-line option for skin, oral, or liver chronic GVHD, the Canadian ones, the Italian ones also, and finally, we also have the ones I mentioned before, the European Dermatology Forum guidelines that also mention ECP as a treatment. So we have different guidelines, and also these guidelines are frequently updated with the new evidence that is generated. Regarding clinical data, these are all the studies in the steroid refractory or steroid dependent chronic GVHD from 1998. All the studies that have been published. Maybe, well, there are different ones. Maybe points out we have a prospective randomized study, the one from Berry Flowers in 2008. It needs to be said that this study has a primary endpoint and secondary endpoint. The primary endpoint has not been met in this study, but the secondary endpoints have been met, and there has been, of course, primary endpoint is not reached, but they have shown that ECP has an impact in the cutaneous involvement of chronic GVHD and also on other organs involvement. Of course, as mentioned also, if you need some of these studies, I can send them to you. You can see that there are mainly prospective randomized. We have one study with 95 patients. We have 3 prospective studies. We have the one from Voss in 2005, the one from Greinix in 2011, and the one from Dignan that has looked at quality of life and the impact of ECP in quality of life in 2014. And after, we have other retrospective studies. Maybe I will go fast because I think we don't have time to go into flowers. One moment, I'm looking into time. How many time we can have more, or?
You can take your time, Carlota.
Okay, so maybe I can go into flowers. Okay, if you want, I can go into flowers, which is the randomized trial we have. Okay, thank you very much. I won't try to take more time. This is the flowers one. I think it's important because this is the randomized study we have, prospective randomized single-blind control multi-center trial of ECP in patients with histological confirmed cutaneous chronic GVHD, 95 patients in total that were steroid refractory, intolerant, or resistant. In the first week, ECP has been given 3 times per week. Half of the patients have been treated with conventional therapy and 48 patients with ECP. So ECP has been provided more intensively in the first week, and after, from the week 2, the second week to the week 12, so until 3 months, it has been provided twice per week on consecutive days. The primary endpoint of this study has been the median percentage change of the total. This was a new, at this point, in 2008, this total skin score was a new tool. So it's something that was validated by one study, and this was the primary endpoint. And this was the primary endpoint at 3 months. So they have not assessed this endpoint at week 24, and I will explain why after. And also they have included other secondary endpoints, which were patients that have a 50% or more reduction in daily corticoid dose. Also the combination of steroid sparing and also improvement in the total skin score. And also the complete response or partial response according to an investigator assessment. And also the change in quality of life assessment results. This is total skin score, which at that time was a new tool in order to assess the skin involvement in cutaneous chronic GVHD. Here you can see that both treatment arms, both ECP and control, were well balanced according to the type of chronic GVHD, the type of, if it was steroid dependent, steroid refractory, the severity of the disease, and the total skin score at baseline. Here you can see the results. So the primary endpoint, as it was mentioned, is the change in total skin score after 12 weeks versus baseline. Here you can see the results for ECP, the results for the control group. And you can see that the median change has been a reduction in 14.5 in the ECP group and 8.5 in the control group. But this was not significant. That's why the primary endpoint is not reached. At week 24, we have data for ECP patient. So we can see that after 6 months, the reduction in the impact in the involvement of the total skin score has been greater with ECP. The problem is that the control group was not assessed because it was not considered ethical that if after week 12 to keep patients in the control group if they were not responding. That's why there has been no assessment at 6 months. Maybe one of the hypotheses is that if we have had maybe here a value for the control, the results may have been significant. I would like to mention also that if we look at 3-month time evaluation, what we have seen as statistically significant is the percentage of patients that have had more than 50% reduction in corticoid dose and more than or equal or more of 25% of improvement in the total skin score involvement. And also they have shown a statistical significant difference also at 3 months in patients that have more than 50% reduction in corticoids and a final corticoid dose of less than 10 milligrams per day. So here we can see also from the start of the study, from baseline until week 24, until 6 months, the impact of ECP in the total skin score. So we can see that there has been a decrease. Here's at 12 weeks where we have done the first assessment versus control, and here is at the end of the study. Apart from having the assessment via the total skin score, there has been also an assessment of the complete or partial response by unblinded investigators. In this case, if we look at this assessment by these investigators, they have seen a statistically difference between the ECP group with a total response of 40% versus the control group of 10%. But as mentioned, this has been the assessment by the unblinded investigators. They have also looked at extracutaneous response, so not only skin, other organs. And here you can see the difference in the group treated with ECP, which is the one in green, and the control group. The one that has been statistically significant, the difference statistically significant between groups has been the eye. And we have observed a trend in a higher response of ECP in the oral mucosa, the eye as mentioned, the joint, and the gastrointestinal tract. Maybe not in the liver, but if we will see after that in a meta-analysis, normally liver in chronic GVHD is an organ that has good responses. So not in this study, but in other studies we have had good responses with ECP. In this randomized study, they have looked at the side effects, the safety profile, and they have seen no serious side effect related to ECP treatment. And more or less, if we look at both groups, the adverse events reported, the serious one, were similar between the groups. It's also important the quality of life assessment. In this case, the difference has been statistically significant. They have used a questionnaire I will show after, and there have been that ECP patients, there have been an improvement by 90% from baseline, and in the control group of only 2.5%. Here is the questionnaire of quality of life that has been used. Remember that this is 2008. Maybe, of course, now we have other questionnaires that can be used. And here we can see the difference. So we have at week 12, at 3 months, this is the difference of the reduction in this questionnaire. And this means an improvement in the group of patients treated with ECP versus control group. So limitation of the study. It's open label. It has lack of sham because it will be not ethical. The total skin score assessment tool, it was a novel tool. Maybe the week 12, 3-month time has been too early as an endpoint for assessment. But as mentioned, there has been an ethical aspect that control arm cannot have, needs to receive an alternative therapy if they were not responding. And the problem is that assessment after week 12 are limited because some patients that were not responding to ECP in the control were crossover to ECP arm. But as conclusion, in this randomized study, it has been shown that ECP has a steroid sparing effect in a cohort of patients where most of them were steroid dependent. There has been, we have seen that this has been not statistically significant, but we have seen an improvement in the total skin score that has been of 14.5% in the ECP group and 8.5% in the control arm. If we look at week 24, so 6-month time, the median improvement that we only have for the ECP group has been of 31.4%. We have looked also the assessment of the unblinded investigator. In this case, there has been a significant difference in favor of ECP patients. If we look at this assessment by unblinded investigator, as mentioned, 40% have responded in the ECP group and 10% in the control group. The safety profile has ECP has been well tolerated in the study, and there has been an improved quality of life after ECP treatment. So I would like to move, I'm finishing already. We have a meta-analysis in chronic, only in chronic, that has been published by Mallinckrodt in 2014. This study has done a review from 1984 until 2012, and they have included complete response, overall response, and organ-specific response. These are all the studies. I mentioned before, 18 studies have been included in the final assessment of the meta-analysis. 1 randomized study, the one from Flowers, 3 non-randomized prospective studies that were mentioned before also, and 14 retrospective trials. This is a summary of the different response rates according to the organ involvement. We can see that ECP, according to this meta-analysis, can be an effective therapy for skin, where with an overall response rate of 74% and this confidence interval. Also for oral mucosa, 72% of overall response, and liver. As we mentioned in Flowers, the response rate has maybe not been so positive, but in general, if we look at the confidence interval, according to the available evidence, liver is also a positive response. And on the contrary, if we look at lung, in this meta-analysis, we only have 48%, 1 of 2 patients respond, but the other not, and gastrointestinal. So we can say that lung and gastrointestinal, the activity of ECP is modest. Of course, this meta-analysis has limitation. We know that NIH criteria that have been published in 2005 maybe are not included in the studies of this meta-analysis because they have still not been used in these studies. Of course, the meta-analysis assessment is limited by the fact that many of these studies that are included don't have a big sample size. We only have one study, one randomized trial, which is the one from Flowers, and 3 prospective ones. And in all the studies, there were maybe different schedules of ECP treatment. But apart from this limitation, we can say that at the end, we have 18 studies included. The complete response rate in this meta-analysis in steroid refractory chronic GVHD has been of 29%, with an overall response rate of 64%. The 1-year overall survival of 49%. In skin, as we mentioned, more than 2/3 of patients respond well to ECP, which is consistent with other studies. So the results are consistent with other studies. In liver, there is a response rate, an overall response rate of 68%. So we can say it's effective. And the only modest activity is in bronchiolitis obliterans and gastrointestinal tract chronic GVHD. Safety profile, I have mentioned before, from 1998, we have different studies. These are in GVHD, in acute. We have studies of, in general, all the studies, they evaluate the effectiveness, the efficacy of ECP, but also the safety profile. So here we can see the safety profile and the reports from the different publications. We cannot say that ECP has no side effects. Normally, there are side effects affecting maybe a decrease in the lymphocyte counts, in the platelet counts, some anemia in some cases, some hypotension because ECP, there is an extracorporeal volume. But in general, the side effects reported, they are not serious. They have been limited and in time, and they have not led to discontinuation of treatment. And also very important, as mentioned before, there is no report of increased incidence of infection linked to ECP or an increase of secondary malignancies linked to ECP. So we have different studies of safety in acute, as mentioned in the table before, and these are in chronic. So the different publications that mention the safety profile of ECP in chronic GVHD. These are all the studies. So the overall safety, these are internal data. So we have post-marketing surveillance of Therakos ECP technology and Uvadex drug. And here we can see that we have a low risk for adverse events and a very low risk for serious adverse events. And here you can see the number, the incidence of these events that we have been reported. Treatment regimen. One question that in many occasions emerged, which is the ideal treatment, the recommended treatment regimen. It has not been established because in many cases it's individualized, but I would like to mention what is stated in the recommendations. So we have regimens that are stated in the different guidelines. For acute, we have ASFA. ASFA mentioned 2 treatments per week until disease response, then tapering to every other week until discontinuation. We have the European Dermatology Forum guidelines. They mention 2 or 3 treatments per week on a weekly basis until complete response and then tapering. And the UK Fotoaférese Society recommendation, which is 2 treatments per week for 8 weeks. And in cases of severe disease, some patients may benefit from 3 treatments. I would like to mention that the recommendation acute have changed in the last times. So for instance, the EDF, these are the recommendations from 2014, but in the last recommendation that they say that when complete response is reached, you can stop treatment. You don't need to taper. So I think that we need to, for acute, there has been a change in the last times that if a patient has a complete response to ECP, you can stop treatment. You don't need to taper, which is different from chronic. In chronic, here you can see the different recommendations. So normally it's 2 treatments per week until response, or more or less until 3-month time, and then tapering until maximal response. Here you have the different recommendations. So for chronic, you normally have more or less a treatment of 2 treatments per week for 3-month time. And then the tapering depends on the response of the patient, the risk factor for this patient. So the duration can be variable and needs to be individualized. But these are the recommendations from these guidelines. So in summary, Therakos immunomodulation in chronic GVHD, there is clinical experience with the Select system, which is the newest device of Therakos technologies. And we have data in the literature of more than 200 adult and pediatric patients that have been treated worldwide with acute, and more than 1,000 patients, adult and pediatric patients treated with chronic disease. The key aspects, according to what has been presented before, early intervention improves outcome. We have seen that an early diagnosis of steroid refractory disease and an early treatment start is important for the patient response and survival. We have seen also that in general, there is more response to ECP when the disease is less severe, despite also having responses in moderate and severe disease states. We have seen that ECP is effective in the different symptomatic manifestations. It's also important that patients that respond in a complete manner to ECP have shown a translation with an improved disease-free survival and overall survival. It's also important the tapering of steroids and other immunosuppressants. Adding ECP as an immunomodulative treatment can help to reduce the dose of immunosuppressants, and this can have an impact in the complications and safety profile. We have seen also, according to the data published, that ECP used in the Select system is a well-tolerated treatment. And here we can see that despite not having in the evidence until 1987, when ECP has been used the first time, there have been some adverse events, but they are normally not serious one. And the one reported can be hypotension and a transient reduction in some cell counts as platelets or leukocytes, but the infections and non-hematologic toxicity are uncommon. And in general, in ECP, regarding ECP in the treatment of GVHD, we know that GVHD is still a common complication and impacts in mortality and morbidity. ECP has demonstrated efficacy and safety in adult and pediatric patients. ECP has until now shown that has an impact in the immune system via different mechanisms, increased Rett cells, shift from pro-inflammatory to anti-inflammatory profile, a change in the dendritic cell types cells, meaning that there is a shift toward a more anti-inflammatory profile, increase NK cells and reduce mature dendritic cells in ECP responders, and increase in myeloid-derived suppressor cells. And also that there are different guidelines that recommend ECP as second-line option for acute and chronic. And that's it for my side. I mean, I have not time to speak about CTCL and solid organ, but we can leave for another session maybe.